Hello, everyone, and welcome to the Sansar Conversation Pro series. Thank you for taking the time to join us. Today, we are starting a new journey, discussing with you about life stages and their implications in oral health. Now, as we'd love to hear from you, feel free to ask as many questions as you like in the YouTube live chat. We will try to answer as many as we can. Also, if you have a specific topic you would love to learn more from, do not hesitate to add them as a comment as well. As information, a recorded version of this webinar will be available here on our Sansar Global YouTube channel. So if you can come back anytime and share it, or you want to ask more questions, it's there for you. At the end of each webinar, we will announce the next event, topic, date, and time. So now we are ready to start with the first chapter of this journey, pregnancy and oral health, challenges and opportunities. I pass the ball to our moderator of the day, Martijn.
Thank you, Marcia, for the introduction, and of course also a big thank you to everyone who's tuning in today. Now, while we're getting started, we'd also love to learn where you're joining from, so feel free to type away in the chat. So me as well, I'm also really excited to kick off this series of webinars, and even more so today because we have an amazing set of speakers ready. So first off, I'd like to introduce Professor Mia Geisinger. Mia is Professor and Director of Advanced Education in Periodontology at the University of Alabama at Birmingham School of Dentistry in the USA. Welcome, Mia. How are you doing?
I'm doing well, Martijn. How are you doing?
Very good. Thank you. Okay, great. So yeah, I understand this topic of today is really something that's close to your heart. That's right.
Absolutely. As a periodontist and a mom, first and foremost, right? This is something that I think we see on a professional level and also on a personal level. And I've been fortunate enough to be involved in research looking at the impact of both periodontitis and gingivitis on oral health in pregnant women and on pregnancy outcomes as well.
All right, great. That's really promising. So now on to our second speaker, Professor Phoebus Madianos. Phoebus is Professor of Periodontal and Dean of the School of Dentistry at the University of Athens. So welcome to you as well, Phoebus. How are you doing?
Hi, Martijn. I'm doing great. How are you?
Good. So I believe this topic is of much interest to you as well, correct?
Absolutely. It has been one of the first topics after in my early career, after my PhD, that I got really into.
Yeah. Okay. Yeah, I see you have a wealth of knowledge on this topic, so that's also really promising. All right, perfect. So let's get started. Some of you who are watching, they might be familiar with the term pregnancy gingivitis. So Mia, to start with you, could you maybe explain us a bit more about the influence that pregnancy has on our periodontal health?
So in the latest classification of periodontal diseases and conditions, pregnancy gingivitis would really be considered a condition that's modified by systemic influence, in this case, sex steroid hormones. But it's been known since the 1960s, when it was first described by Silness and Lowe, that even in the cases where there wasn't a difference in biofilm mass, there seemed to be a great increase in the amount of inflammation present in pregnant patients, and it seemed to increase over the course of pregnancy, peaking and plateauing within the second trimester generally, and then staying steady until birth, until parturition. And generally that resolved. And many of us have also seen pyogenic granuloma, which is sort of the supercharged version of this, right? Where we have an overreaction to etiologic factors, plaque and calculus, and certainly that dysbiotic plaque biofilm.
So yeah, that's, I understand. So the mechanisms underlying the association, that's increased inflammation, maybe you could even say an exaggerated reaction to the dental biofilm. And how would you quantify this association in terms of epidemiology? How big is this problem?
So the studies really vary, but the range has been shown to be somewhere between 57 and 100%. So somewhere in the range of a lot of people who are pregnant have in fact this interaction, and this is significantly higher. And the extent and severity of the gingivitis are also significantly higher than in age-matched non-pregnant controls.
Wow. Okay. Yeah, Phoebus, can you maybe comment a bit more on this? What do you know about the increased inflammation, the role of inflammation, and the role that hormones play in this association?
Right. I mean, as Mia already has alluded to, it's well known that pregnant women do have problems with their teeth, basically their gums. I mean, that's common knowledge since many, many decades ago, or even centuries. So it's really common knowledge. So how this works, obviously, Mia has already said a few things about the pathophysiology of it, and definitely has to do with the elevated levels of hormones in pregnancy. What has not been shown is that if you have gingivitis, pregnancy cannot turn this into periodontitis, which is, obviously the next level, which, you start to lose bone around your teeth. But in terms of people in terms of pregnant women that start their pregnancy with periodontitis, actually, there are some data showing that their periodontitis can actually get worse during pregnancy, exactly because of this elevated inflammatory reaction due to the hormones.
Okay.
And potentially alterations in the qualitative nature of the biofilm as well. And I think you'll talk about that a little bit more, Phoebus.
Absolutely, yes.
So, Mia, you mentioned that after partition, usually the gingivitis resolves or easily resolves. Are there also cases where you see that it prolongs, or that it sort of makes a pregnant women after partition more prone to develop into more severe forms of periodontal disease?
So we don't have great data on that. But one of the things that we know is that there are patients who have persistent inflammation over time. And we certainly are concerned about establishing oral health prior to pregnancy, and then throughout the pregnancy, maintaining that oral health and those good oral hygiene habits, so that can then carry both mom through life, but also that mom can teach her offspring about good oral hygiene habits.
Interesting. Now, when I think of out of the perspective of a dental care professional, are there maybe ways to spot an emergency in the dental chair?
So when we're treating pregnant patients, it's important to know what are some of the risks associated with pregnancy. Certainly, there are some positional concerns late in pregnancy. And for invasive procedures, generally it's considered that the second trimester is the safest to treat. But realistically, if a patient needs therapy, delivering oral treatment, whatever that may be, is safe and effective during pregnancy. There are obviously unexpected outcomes in pregnancy, things like preeclampsia, where you're going to see a spike in blood pressure in pregnant patients that can be life-threatening. And so making sure we're doing all of the medical screenings, coordinating with the perinatal team, and making sure that we are really thinking about addressing the underlying concerns. But treating oral disease during pregnancy is something that we can and should do. And I don't think that was always our perspective as dentists, but we really have evolved in that way.
Yeah, that's really good. Yeah. Okay, really interesting. Yeah, so when we look at this as holistically, so from the whole body, talking about the influence of pregnancy on periodontal health, the other way around apparently is also true. So apparently periodontal disease can also have an effect on pregnancy outcomes. Maybe you, Phoebus, you can maybe shed your light on this. And as far as I understand, you wanted to start with a short statement on a very close friend to both of you and of the whole periomedicine community.
Yes, actually, maybe 3 decades ago, if somebody said that, gum disease can influence pregnancy, we'd probably consider this person, not very sane. Let's say that. And to tell you the truth, when I was doing my postgraduate studies and I saw the first publications by Professor Stephen Offenbacher, when he experimented with hamsters, pregnant hamsters, and he was the first one to show that infection with some periodontal bacteria can actually influence the outcome of pregnancy in that experimental model. We all thought that, that was a far-fetched idea. And I have to say that I have been extremely lucky that a few years later, I had the chance to move to Chapel Hill, to the University of North Carolina, and collaborate closely with Professor Stephen Offenbacher, which is, was one of the brightest, minds in not only periodontology, but in dentistry in general. And actually, he's considered the father of periodontal medicine. In general, a general term that alludes to the influence of periodontal disease or gum disease to the rest of our general health, to conditions obviously like pregnancy and to other systemic diseases like cardiovascular, diabetes, and so forth. And I was, again, lucky enough to move to Chapel Hill and start working into this association on how periodontal disease can, in fact, influence pregnancy. And, we did a lot of studies, some experimental, some clinical studies, and the clinical studies show that the fetuses that had an antibody response, an IgM response against periodontal bacteria, they had a much greater chance in being born prematurely or at a low birth weight and so forth, which in turn means that bacteria from the mouth, from the periodontal pocket, from the gums, can travel through circulation and reach the fetal placental unit or the placenta, and there they can, elicit inflammatory reactions, or they can even enter the barrier and infect the fetus directly, and thereby influence the outcome of pregnancy.
Really interesting. So already 20 years ago, there was already some evidence of a biologic association between periodontal disease and pregnancy outcomes.
Yeah, 25 years ago at least.
Yeah, wow. It's already a long time ago. And since then, I assume a lot of research has been done. How has that evolved? What is the current state of evidence in terms of, for example, epidemiology?
Well, since then, there have been a number of epidemiological studies done around the world, and basically they had various outcomes and various results, rather conflicting. So in some populations, this association was found to be quite strong, while in other populations, no association could be found between the periodontal condition of the mother and the outcome of pregnancy. And of course, there could be many reasons for these conflicting results, but I don't know if you want to go into in detail. But the message is that in certain populations there is a strong association between the periodontal status of the mother and the outcome of pregnancy. Well, in other populations, this is not evident.
Okay, so there are some predisposing factors in certain populations. Maybe can you share a bit of what those factors could be?
Well, except from racial differences, obviously, that can explain some of that variation. There could be differences also in the in the care of pregnant women that can vary from for different populations. How these women get into pregnancy in terms of their oral health. There are a number of reasons why these differences occur in epidemiological studies.
Okay, yeah, really interesting. I mean, that's also determining policy, I assume, targeting really the specific populations as a risk groups. Yeah, really interesting.
Martijn, I think it's also important to note that when we're looking at some of these epidemiologic studies, they are case control studies, but they're comparing periodontitis and non-periodontitis. But the non-periodontitis patients may not be classified as health. They may actually have a significant amount of inflammation. And as we know, pregnancy may upregulate that inflammation. And so that may dampen the differences between those groups.
Yeah, that's a very good point. Yeah, that's a great point. And I see that we have this drawing coming up. Just to say a few words, if I may. Basically, it just shows what we just briefly said before, that bacteria can enter from the gums into the circulation, and then they can either increase systemic inflammation, which in turn can influence the placenta, or even more evident from many studies, some of those bacteria can actually travel and reach the placenta itself, and they cause local inflammation with various consequences, and even cross the barrier, infect the fetus directly with even worse consequences. And there is evidence for that. There are not huge studies, but there are some reports showing periodontal bacteria that have been isolated by cases of either miscarriage or cases of preterm birth, apart from the study that I alluded before with the antibodies. But also there is this new study that not new anymore, but the past decade at least, that actually showed that the placenta itself is not sterile as we thought. But the placenta has a lot of bacteria colonizing it, and the microbiota, or the microbiome of the placenta, is very similar, surprise, to the oral microbiome, and not related at all to, let's say, the gut or the urinary tract microbiome, which would probably be more expected, if I can say.
Yes, especially when you consider the proximity of these other microbiomes to the placenta compared to the oral microbiome, which is possibly the furthest away. It's really surprising to see these bacteria colonizing the placenta. Are there any explanations or theories that might explain why this is happening?
Well, as we said before, it's actually well known that patients with periodontal disease obviously have bacteria from their, dental plaques, from their biofilms, that enter into the gum tissues, and then therefrom, through the capillaries and the small vessels, these bacteria can reach the circulation. They travel through the circulation, and they can reach distant parts of the body, obviously not only the placenta, but they have been found in other areas as well, which is something that we need to keep in mind, that this is an infection, really, and that infection is in the same body. The oral cavity is part of of our body as well.
Yeah.
And people have tended to forget for a long period of time. But this is what happens.
And those bacteremias are really proportional to the amount of inflammation, not necessarily the type of clinical attachment loss that's present. So potentially in pregnancy that potentiates that gingival inflammation that's present, we could see an amplification of those bacteremias for those pregnant patients. And I also think that some of the population differences that Phoebus described earlier potentially could be explained by this mechanism, because we know that antibodies could be present. So in patients who are relatively naive to some of these oral bacteria, they may actually have a more robust reaction if those bacteria enter the placental environment and the amniotic fluid than individuals who might have had pre-existing disease. So it's, there's a lot of things to pull apart and suss out here. It's very, very interesting from a scientific standpoint.
I can imagine. And I can also imagine it's really difficult to establish causal relationships because of course, all the ethical limitations research has, but at least there's some biological explanations that are sounding really plausible and can actually be shown in research, and that's I think it's really interesting. Okay, nice. So when we then consider, okay, we have inflammation, we have maybe bacteriemia causing inflammation at different sites. Could you then also maybe assume that when you take away the inflammation by treating patients, taking away the bacteria by treating those patients and good oral hygiene, does that also affect pregnancy outcomes? Does it have a protective effect? Can someone
if Mia, would you like me to go first, or you can go first if you like?
You go first, because I have a follow-up comment.
All right. Thank you, Mia. So yes, obviously there have been studies that looked at how periodontal therapy or treatment of periodontal disease can influence or can improve hypothetically the outcome of pregnancy. At the beginning, there were some smaller studies that actually were very promising, showing reductions in adverse pregnancy outcomes after at the group that received periodontal therapy. After that, there have been a few studies, much larger studies, that were not able to show a benefit of periodontal treatment in terms of reducing adverse pregnancy outcomes. And again, there is a number of explanations for that. And if I may say a few, and I'm sure Mia will add a couple as well, is that obviously number one is how effective periodontal treatment is. And periodontal treatment has not been as effective in reducing periodontal inflammation in all of these studies. In fact, those studies that showed a much better reduction in periodontal inflammation, in other words, a better outcome of the periodontal treatment itself, were able to show that that was effective in also reducing adverse pregnancy outcomes. But that's only one part of this explanation. The other part, obviously, is the timing of the intervention, the timing of the periodontal treatment. And in most of these studies, actually in all of those studies, that treatment occurred at the second trimester of pregnancy. And in many cases, that could have been a little bit late to intervene because, pregnancy just only lasts 9 months and sometimes obviously less than that. Yeah. So if you treat at, let's say, the 5th month, it's already all of those things and the mechanisms that we talked about before maybe have already happened, so the timing in itself is very important, and it needs to be taken into account for future intervention studies. And yeah.
So I appreciate appreciate Phoebus kind of setting the stage, because I actually had a personal anecdote that I wanted to tell, and it involves obviously Dr. Offenbacher. So one of the large multi-center trials that was done looking at this as far as an intervention is concerned in the United States was called MOTOR. And the treatment itself was strictly non-surgical therapy delivered within the second trimester, and there was no other intervention in the intervention group. So there was no ongoing oral hygiene intervention. There was no treatment to an end point, which is most of the time what we do in periodontal therapy. And the examination after parturition occurred within 24 hours of delivery in the hospital in many cases. And you had to go in and actually perform a comprehensive periodontal exam on women who had just given birth, which, as you can imagine, made it very, very popular. But one of the things that we found was it was very difficult to tell the individuals who had received intervention and those who hadn't, because of the level of inflammation that continued to be present. And so I think looking at this from the standpoint of gingival inflammation and reduction in that inflammation, and also alteration of that dysbiotic biofilm, is critically important. And realistically, that's going to be both treatment to an endpoint, timing the treatment appropriately, and making sure that patients are really delivering home care, self-delivered home care that's appropriate for the reduction of inflammation in these patients.
Yeah, good addition. So if I understand correctly, if you start planning a family, you should first start brushing properly and go to the dentist to have a dental checkup. Is that correct?
Well, actually, the American College of Obstetrics and Gynecology recommends that in the 6 months leading up to becoming pregnant, if one is planning to become pregnant, that one make sure that they have a full comprehensive exam with their dentist and establish good dental habits, a dental home, and a full bill of dental health. And if an individual is pregnant and they haven't been to the dentist in the intervening 6 months, it's recommended that they go to the dentist at that time.
Those are really good tips, I think, for people with family plans, I think. Very good.
And that goes for their male counterparts as well.
Always.
Right, you can pass it back and forth. It's perfect.
And what about, because in the beginning we mentioned, okay, pregnant women are more prone to gingivitis because of the hormones. How effective is the oral treatment in terms of oral outcomes when you consider that they still have these elevated levels of hormones and still prone to inflammation? How effective is oral treatment? Should we consider that as well?
So one of the things that has really been a shift over the last several decades, and Phoebus mentioned this, it's really been a paradigm shift in dentistry. It used to be when a woman got pregnant, it was like, okay, we'll see you in 9 months. But what we know now is that ongoing preventative and interventional care during pregnancy is really critically important. And so here at UAB, we actually did a study where we recruited essentially under MOTOR, so inclusion exclusion criteria, where the patients had high levels of inflammation, an average gingival index of 2 at least 50% of the teeth, but they had not yet had periodontal destruction. So very significant gingivitis, but no periodontal destruction as of yet. And we took these patients and we treated them with an intensive oral hygiene regimen. So essentially, they got text messages and reminders to brush and floss. They got sort of a bevy of oral care products and exams at maternal care visits on a monthly basis with reminders. And we were able to significantly reduce all of the periodontal clinical parameters in these patients, probing depth, GI, PI, and clinical attachment level, and also significantly reduce the periodontal inflamed surface area score, which is a really excellent measure of the amount of ulcerated epithelium that's present within the periodontal sulcus or pocket, and is related to the influence of that ulcerated epithelium and gingival inflammation on systemic disease.
Okay, so your recommendation would be yes, periodontal treatment is safe. It should be done.
Effective, and gingivitis is not a fait accompli for pregnant patients. It still stands to reason that healthy tissue should not bleed when we strike it, and so blood in the sink is a sign that something is going wrong. And while it may take a more intensive oral hygiene regimen in pregnant patients, it's critically important that we intervene because it could be significant for both mom and baby.
Yeah, so dental care professionals should really pay attention to these first alarm bells of gingival inflammation when they see a pregnant patient in the chair.
Absolutely.
And act accordingly. Okay, yeah. Well, with all this knowledge that's available and has been available for a few decades already, I'm sure that all the pregnant women are already receiving optimal oral care, or am I being a bit too optimistic here?
Unfortunately, Martijn, I think you are. And while the U.S. system is slightly different than systems elsewhere globally, because of our payor system and a difference in the integration levels of medical and dental care, a survey from the American College of Obstetrics and Gynecology, ACOG, mentioned that only 60% of patients receive preventative dental care during pregnancy. And if they understand the importance of dental care, they're 40% more likely to seek out and receive that care. So coordinating with the perinatal team and the individuals who are going to see these patients throughout their pregnancy for their prenatal care is also important because they can direct those patients to the dental office if they don't have a dental home already.
Phoebus, do we also have data about that in Europe, or are you not aware about any study?
Well, I can't give you any exact figures from any large study in Europe. However, unfortunately, I think things are not much different in Europe as well. There may be small differences.
My fingers crossed.
Yeah, there may be, obviously small differences in some of the countries that are definitely, they have a more preventive dental healthcare system in place anyways, and that obviously has affects also pregnant women, and that could be Scandinavian countries that do have these systems in place. But overall, I don't think that there is any particular preventive oral healthcare system in place in most of the countries, and as Mia said, that's definitely something that for people planning to have a family and for women planning to get pregnant, there should be a strong message out there to really get their oral health really in a very good shape before. And there are some very small studies that I'm aware of looking at women that plan to be pregnant, with in vitro fertilization processes. And that is also quite important to note that these are definitely cases that do have their planning in place. Sometimes pregnancy can happen without planning, but in these cases, it's definitely planned. So in these particular cases, it's important not only to spread the message to the women, but also to our colleagues, to our gynecologist colleagues, to actually make sure that they make it, they stress that point to their patients, to visit their dentists and really get their oral health in a very good shape before they get pregnant.
And Phoebus, you mentioned emerging evidence. There's actually, I'm aware of 2 studies, you may be aware of more, but some emerging evidence that looks at male fertility and periodontal disease, and how periodontal disease may affect male fertility as well. So both partners in those couples would benefit from excellent oral care.
Absolutely, and that's a good point. There are studies that actually started, back then. We actually looked at some of those, specimens, and there were some of those studies have shown that even periodontal bacteria can reach even, at that, level, the male sperm. But more importantly, women that are planning to get pregnant, they definitely need to get their oral health in a good shape before, rather than trying to get it afterwards. Without that saying that, as Mia said, that we cannot treat the pregnant women. Of course, we can treat them, and we should treat them. However, it's much better if you enter pregnancy with a healthy mouth.
Yeah. So I think the urgency is clear. How do you envision this from a healthcare professional's perspective? How can dental teams and perinatal teams collaborate to tackle this problem proactively?
So, I think that this is a critical collaboration. If individuals come into their OBGYN or their nurse practitioner or their midwife's office newly pregnant, one of the things that they go through are, well, what screening procedures have you had? Are you up to date on your vaccines? A checkbox question should be, when was the last time you were at your dentist's office? And if we can incorporate that into the electronic medical record and into the screening at the perinatal team's office, this could be a critical component to make sure that we're seeing patients as early as possible in pregnancy if they have not already established a dental home. And then furthermore, I think that it's critically important that individuals who are seeking to become pregnant are counseled about making sure that their oral health is taken care of as well. And I really think that this collaboration is something that we can grow. And I know that for us here at UAB, this has been a very fruitful collaboration. We actually had a dental operatory installed in the Center for Women's Health here at UAB, and we were able to see patients at their regular prenatal visits. And these are patients who are generally receiving state-sponsored insurance, so they would not qualify otherwise for dental care based upon the U.S. system and the system here in Alabama. So this really is an excellent opportunity to intervene on patients who would likely be lost in our system otherwise.
Yeah, so Phoebus, you were even involved in drafting guidelines on this topic, I believe. Could you maybe share some findings and some advice from those guidelines?
Yeah, and this has been a very important initiative from the European Federation of Periodontology to actually collaborate with our colleagues, the physician colleagues, to produce guidelines for the first time, not only for dentists, but also for our physician colleagues. And I think that initiative has already gone a long way, and the local national societies are spreading this message as well. And it really needs to reach, as I said before, the colleagues, the gynecologists that should advise their not patients, but they should advise women that keeping their oral health in a very good shape, that is important, not only for the teeth, but also for pregnancy outcomes, and it's an integral part of their prenatal and under pregnancy, care.
Yeah. Good. Now, with my eye on the time, I would like to end this series of interesting topics with a positive note, because Mia, one of your interests is actually exploiting the period of pregnancy as an opportunity to achieve something. Could you maybe share a bit about that?
So one of the things that I think is critically important is that pregnancy is really an opportunity. And as someone who has been pregnant, I can tell you, I gave up wine for 9 months for my baby. And I don't do that for anybody. But in all seriousness, positive behavior change during pregnancy is really a critical opportunity. And pregnancy has been identified as a time when women are more likely to make those positive behavioral changes, particularly those that will benefit their fetus. Tobacco cessation rates in pregnancy are 2 to 3 times higher than in other life stages, and patients who quit during pregnancy are more likely to stay quit. And the incentive there was really health benefits, particularly those to the fetus, much more so than financial benefits or external motivators. So if we can take the time to counsel our patients about the benefit of, in particular, self-delivered oral hygiene for themselves, their oral health, but also the potential impact on their fetus, that could have a lifelong effect. They have 6 to 9 months when they know they're pregnant to make that habit stick. And we also know that maternal oral hygiene has been associated with better maternal oral hygiene has been associated with decreased rates of early childhood caries in their offspring. Because if that mom can teach her son or daughter the proper way to brush their teeth, and that if mom feels that oral health and oral hygiene is important, they're more likely to seek a dental home for their offspring. They're more likely to be compliant with recommended dental visits, and they're more likely to have lower caries rates in those offspring. So the impact is really huge when we think about pregnancy as an opportunity to make those changes.
So not only a challenge, it's also an opportunity. I think that's a really nice way to end this discussion. I think we have some questions from the audience who tuned in. So the first one: does pregnancy influences the speed of evolution in periodontitis, so the progression of periodontitis?
So as Phoebus said, we don't generally see gingivitis jumping to periodontitis just because a patient is pregnant. However, we can see an increase in the amount of inflammation, and that can be associated with increased disease progression in those pregnant patients.
Yeah, and if I may say so, in some of the longitudinal studies that have been done, the patients that entered the study having periodontal disease, they had a much larger number of sites that actually got worse during pregnancy, and meaning not only having more inflammation, but actually losing more attachment or losing more bone. And in fact, I think that's an indication that yes, pregnancy can accelerate, if we can say that, periodontal destruction in some cases.
Okay, the next question: does pregnancy gingivitis affect the baby? And I think, Phoebus, you touched upon this briefly with the inflammation and the bacteria reaching the placenta. So maybe you could answer this question.
Yeah, and Mia said that as well. Yeah. That it's not just how much attachment someone has lost before going to pregnancy. Basically, what's important is what is the bacterial challenge that the fetal placental unit has during pregnancy. And the bacterial challenge has a lot to do with the amount of inflammation that is present at the time of pregnancy, which makes it very important. Not only periodontal disease, but also gingivitis, very important.
Okay, let's see if we have more questions. Could you help to elaborate more on why periodontitis could influence male fertility? I think that's a really good question for us.
Well, definitely, I'm not an expert exactly on that. However, the idea behind it is basically, as the main idea is how periodontal disease can influence a number of different systemic conditions or diseases. And that is by, number one, increasing the systemic inflammatory level that one has, and we can measure that through different, elevation of different markers of systemic inflammation, and that can influence in itself a number of things. Of course, the cardiovascular system, which has to do with fertility as well, but also there is the more direct way that we mentioned before, and that is through bacteremias that occur. The different bacteria can reach distant organs and thereby influence directly those organs, whether that is, the fetal placental unit or the placenta itself, or whether there is, male organs, sexual organs. And as I said, there are some reports showing evidence of periodontal bacteria in the male sperm. So, I mean, there are a number of reasons why one could think that there is a connection or an association. But having said all that, we must say that the evidence at this level is very, very, initial. It's not something that we can, make any strong statement about. But there is evidence that there may be a connection.
And there are analogous diseases that induce a hyperinflammatory state, and conditions like smoking or obesity that also have similar effects on male fertility. So that's the hypothesis behind it and why it was initially investigated. I don't think we know enough about the underlying mechanism to go into a whole explanation, but that was sort of the thought behind actually looking at male fertility and its relationship to periodontitis.
Okay. Let's see if we have more questions. Yes, we have another one. How would you approach delivery of care in an individual who had a complicated pregnancy?
So this is another opportunity for the collaboration with the perinatal team. I think a medical consultation and scheduling that patient is critically important. And I also think that, not all pregnancy complications are created equul. There are patients who have, for instance, premature rupture of their membranes. And those patients need to be on bed rest. Well, they may not be great patients to receive preventative oral care, but there are patients who have other conditions where they may be suitable to receive care under optimal environmental conditions. So those patients may need supplemental oxygen, or they may need to be positioned in the dental chair in a way that's advantageous to them. So I think it's critically important to look at the individual patient and what the pregnancy complication is.
Okay, thanks. Thank you. Yeah, I see we're already running over time, so I think that was more or less the questions that we were able to answer. Of course, if you have more questions, feel free to put them in the chat, and we will try to answer them later if we're able to. In any case, I want to thank the speakers first for today. Phoebus, very much for your expertise and for your presence, and of course the same for you, Mia. I think it was really interesting to hear you speak, and I'm looking forward to hear more from you in the future, hopefully.
Thank you, Martijn. It's been great.
Thank you, Martijn. It has been very,
okay, and
nice.
Have a great day. Bye-bye. Okay, so that brings us to the end of this webinar. The next webinar will take place over a month, so the 8th of April. And during this webinar, we will tackle the prevention and management of caries in children. So for now, I thank you for your attention. I thank you for your questions and for all the engagement you put in. And I really look forward to connect with you in over a month for our next webinar. So thank you and enjoy the rest of your day.